This conference will now be recorded.
Good afternoon, everyone. On behalf of Shreyas E-Learning Academy, we welcome you all in this our next session of Arsha series. So we are very fortunate to have with us today Dr. Tushar Shah sir, who will be taking management of fishery nano to various techniques. Dr. Tushar Shah sir has completed his BMS in 2003 from JP Ayurved College, Bhavnagar. Sir has completed his MD in Kai Chikitsa in 2009 from Ayurved College, Ahmedabad. He is currently at Government Maniben Ayurved College, Ahmedabad. Sir has been working exclusively in the field of proctology since last 10 years. Sir has been founder, president of Sushrut Proctology Association, Gujarat. He has been given many live demonstration surgery at various state and national level seminars. He has been regularly invited as a faculty and a resource person in state and national level proctology seminars. He has an active participation in numerous diagnostic and surgical and rectal camps. Apart from this clinical activities, we would like to mention that he has also been a 5 times consecutive champion at Gujarat Ayurved University level in table tennis also. So, taking much of his time, we'll request Dr. Tushar P. Shah, sir, to please start his session. Thank you, sir. Over to you.
Good afternoon, everyone. First of all, I would like to thank Shreyas E-Learning Academy to invite me to give this academic session. If not academic, it will more of a practical session for the management of fishery nano. Frankly speaking, I don't want to be here explaining the text or various academic aspect of fishery nano, but I'll be more focusing on the practical management, on the surgical aspect, on the complications, on the recent trends, the complication that I have faced, the things to avoid the complication in the surgical management of fishery nano, and some understanding of etiopathogenesis of fishery nano along with Ayurveda and modern parameters. Sir has given a vivid description of myself, so I won't what to say. Waste my time in giving my introduction. I would like to say. Just a minute, sir. Blessings from Lord Dhanvantari before starting any academic session, and I would pay my respect to the source of my inspiration, my Guru Varya, Dr. Devendra Kanayuraj Shah, who is presently working as an RAV Guru at Ahmedabad. Now, why I have selected this topic for the management of fishery nano? Friends, it is very much considered as a bread and butter surgery. कि फिशर है तो उसमें क्या ज्यादा सोचना, डायलेट कर दो और फिशर बेड को निकाल दो. Just go for the dilatation and do the fissurectomy. It is not like that. In the proctological practices, about 50% of the total case that any proctology institute or a private setup counters, 50% of them are fishery nano. It is very common, but still it demands a lot of consideration and pursuit. उसमें बहुत सारी चीजें हैं जो आपको देखनी चाहिए, समझनी चाहिए, because if not done properly, there are lifelong complications. And the more work you do in fishery nano, you'll come to know that there is a very good scope of improvement. You do a surgery, a surgeon does a surgery, a Bengali Madrasi or Jhansi person does a surgery. For the surgery of fishery nano, it is going to heal. But what is more important? We heal the fisher bed in the most scientific manner. We do a surgery that has got least complication. It is least painful, and the recurrence rate are still less. So you have to learn yourself in such a way that even if you do a surgery of a very commonest entity, that is fishery nano, you should attain these parameters. And there is always a scope of improvement. I have tried to inculcate the recent trends, and I'll give 5 minutes to understand the classical view of Fisher in ano, that is Parikartika. And once again, I'll say that I'm not here to teach the text, but I'm just here to simplify the practical aspects in the management of Fisher in ano. Now see, what is Fisher in ano? In your UG studies, most of us have encountered this question that give in 5 marks or 10 marks, differentiate between Parivartika and Parikartika. And there is a concept in our mind that Parikartika also comes under the roof of Shudra Rogas, but it is not that. Parikartika in Ayurvedic text has been described in Virechan Vyapad. It is there in the Basti and Basti Netra Vyapad. It is there as a symptoms or an updrav of Vatikatisar. Kashyap has inculcated this disease as a disease of a gravid woman. So more or less it is a symptom, it is not a disease. And I would like to focus on this Vyan Avrutapan. It has been described in Vatvyadi Chikitsa, that is chapter number 28 in the Charak Chikitsa Stan. In the Avran Prakaran, there is a symptom, there is an entity called Vyan Avrutapan, and Parikartika is one of its outcome. And furthermore, it has been described into a primary and the secondary causes. Now, what is this Vyan Avrutapan? See, Avran, as far as I understood, it was always difficult for me, even in the UG or the PG studies. I was never able to understand this concept of Avran, and it was an option for me, even if it was asked in the exam. Now see, I'll try to say what is Vyan Avrutapan. See, there are many functions of the Vyan Vayu, but one of the functions of the Vyan Vayu is Ankuchan and Prasaran. Okay, Ankuchan and Prasaran is one of the functions of the Vyan Vayu. And the functions of Apan Vayu is Niskasan of Mal, Mutra, Shukra, Garbha, Artav. It's Niyaman and Niskasan. See, this is the functions of Apan Vayu. Now, when there is an Avran of Vyan in the Kshetra of Apan, now how to understand this? I'll go to a slide. Just a minute, my laptop is hanging, some problem. See, this is a Meditunes. I'll try to explain this concept of what is Vyan Avrutapan. Now here you can see the Kshetra is anal canal, and you can see over here, this is a hard fecal matter, and these sphincters are not able to contract and relax properly. This mechanism of sphincters not contracting and relaxing properly, and hard fecal bowels leads to Fisher in ano. We'll see this once again. This is the Kshetra of Apan, Niskasan of Mal, and for smoother evacuation there should be constant and persistent relaxation, Ankuchan and Prasaran. If that is deviated, we get a Fisher in ano. So, Ankuchan and Prasaran, if doesn't happen properly, there is always a trauma in the anal canal that leads to Parikartika. These are my views of understanding Vyan Avrutapan, and as Parikartika is one of its symptoms. Now this is Arshas. The definition is very explanatory. Arivato pranino maskilaka visasanti yat arshasi tasmad uchyate gud marg nirodhat. So anything that obstruct the anal canal, according to Ayurveda, it is Arshas. So Arshas are not only hemorrhoids. Any anorectal pathology that obstructs the anal canal comes under the wide umbrella or the nomenclature of Arshas. So according to my understanding, other than Vyan Avrutapan, Parikartika means Fisher in ano with or without sentinel tag that is obstructing the anal canal is Arshas. So Parikartika is a type of Vatik Arshas. Okay, these are the 6 types of Arshas. Now, what is Vata Jarshas? Acharya Charak and Shishrut gave a vivid explanatory notes about Vata Jarshas. That is, Shushka Mlan Kathina Parusha Ruksha Shavani, Tikshan Agrani, Vakrani, Sfutit Mukhani, Visham Visrudani. So, this type of entity, that is external hemorrhoids or fissure with tear, are nothing but they are Vati Jarshas. Acharya Charak also described various types of varshas in accordance with the nature. So Shikhi Tundavat Arshasam. See, here is this very clear. This is a peak of a peacock, and these are painful skin tags. We have a very good resemblance of Shikhi Tundavat Arshasam. This Shikhi Tundavat Arshasam can be very well correlated with painful external skin tags with chronic fissures. So this was something about the inculcation of Parikartika, understanding of Vyamavrutapan, and Vatic type of arshas with fissure in ano and sentinel skin tag. Now 4 folds of treatment of arshas. If Parikartika is arshas, how to treat them? What are the basic principles in Ayurveda that you can treat Parikartika? Acharya should give a very clear examples, clear description that is Chaturvidarshaso sadhanopaya tadatya aushadam agni shastram sharam. So here Vatic type of arshasas are definitely agni sadhya. Why? Because see, here is a clear cut examples of chronic fissure bed with a sentinel tag, and here is the hypertrophied anal papillae. This I'll explain you later that this is a clear-cut indication for a surgical intervention of chronic fissure in ano. And here, this is the indication. Karkasha sthira pruthu kathina agnina means rough, immobile, broad base and hard type of arshas should be dealt with Agni Karma. So this is a chronic fissure bed accompanied by a sentinel tag, accompanied by a hypertrophied anal papillae, that is known as trade of fissure in ano. And according to Ayurveda understanding, this had to be dealt with Agni Karma. So this was about the Ayurvedic understanding, etiopathogenesis, and mode of surgical management of fissure in ano, Vatikarsha, Parikartika, according to Ayurvedic principle. Now, what is the etiology in the according to modern medical field? See, this is very clear. Etiology, pathogenesis, and clinical features. I'll just take 2 minutes. See, this all occurs because of a vicious cycle. एक काल चक्र होता है. तो काल चक्र किसका होता है? Constipation, leading to hard fecal bowels, leading to a trauma in the anal canal, and development of the acute fissure. This fissure that is developed below the dentate line is very much rich in the nerve supply. So, because of that, it is very painful. And this pain in the anal canal, say patient is very much frightened and he or she hesitates to pass the stool because of the fear of that pain. So what happens? Wake Sandaran, patient को डर लगता है अभी मैं टॉयलेट के लिए जाऊंगा तो मेरे को फिर पेन होगा और वो the patient restrains from going to the toilet. Again it is accompanied by constipation, more hard stool, again a trauma, and it becomes more painful. So this cycle of constipation, hard stool and trauma are increasing each other. This increasing cycle ultimately leads to an acute fissure getting converted into a chronic fissure. So in management, you have to break this cycle. How to break this cycle? Curing the constipation with laxative? No, it is not the answer. You have to change the lifestyle. That I'll tell you later on. So this is a clinical, what are the clinical features? Patient is having immense burning pain during and after defecation that may persist from minutes to hours. There is a streak of blood on the, see, whenever patient says, मेरे को खून गिरता है और टट्टी पे चिपक के आता है, first thing that should come in your mind is a fissure in ano. Okay, so this type of clinical features, they're all said in the textbook. I'll not take more time. How to diagnose? History and physical examination is the only way to rule out the diagnosis of fissure in ano. Now see, differential diagnosis is very important. What is fissure in ano and what is an anal abrasion? See, both the things are were present in the same patient. See, here in the posterior midline, you can see a fissure in ano, and here at 1 o'clock, you can see the anal abrasion. What are the differences? Fissure in ano is a deep ulcer, where abrasion is a superficial ulcer. There is never a sentinel bile in the abrasion. There is never an anal papillae that I have explained earlier in an abrasion. There are never overhanging edges in abrasion. There are rarely lateral, but abrasions are mostly lateral. Fissure in ano is a chronic condition, while anal abrasion is a transient condition. Fissure in ano is often treated surgically, where no surgical intervention is ever needed in an anal abrasion. So never get your mistakes by saying an anal abrasion as in fissure in ano. This is very important. This, I think, differential diagnosis is most important. Intersphincteric abscess. Patient comes to you with a severe pain. So whenever there is a pain and there is and nothing is seen outside, means there is no hematoma, there is no thrombosis, there is no ischiorectal abscess, there is no bulging of the fossa, then what we suspect? Primarily, we suspect fissure in ano. But many a times it is misdiagnosed, or you fail to differential diagnose with an intersphincteric abscess. Intersphincteric abscess here in the intersphincteric plane, which is a red color border is there. There is a development of an abscess, and that is also painful. So how to do DD? That is differential diagnosis with anal fissure and intersphincteric abscess. This is very important. Secondary causes. आयुर्वेद में बहुत अच्छी तरह बताया है कि व्याधि को पहचानो और उपद्रव को भी पहचानो. Many a times we treat the updrav and we do not think about the main vyadhi. So here are the secondary fissure in ano. You have to be very careful in diagnosis of the secondary fissure in ano, because it is very clearly said, Rogamado parikshet tad anantaram aushadam. So there are some cases where fissure in ano need not be treated. The underlying etiology, the underlying cause needs more attention, and you have to treat the underlying causes, and the updrav will get automatically treated. The first one is the Crohn's disease, and second one is the ulcerative colitis. They come under the umbrella of inflammatory bowel disease. Intestinal tuberculosis is very important. It is only diagnosed either by the RT-PCR of the fluid or the biopsy. Syphilis, STD. See, those are the cases of fissure in ano with syphilis. They have a very peculiar presentation, that the fissure may be lateral. There is hyperatonic internal sphincter, so spasm will not be there, and the fissure bed will cross the dentate line. This is the most important. Fissure bed crossing the dentate line, fissure on the lateral side of the anal canal, and hypotonic anal sphincter are suggestive of syphilis. There are many fissure because of the CA or in the HIV cases. There are some pseudo fissures secondary to hemorrhagectomy. You have to be very careful. You have to just do the wound management. You need not treat the fissure in those cases. And other two varieties, that is the pudendal entrapmental proctolgeal futex. There are some fissure with hypotonic anal sphincters. Means spasm वहाँ पे नहीं रहेगा. There will be fissure, and patient will feel some deep pain. So you have to take into consideration pudendal entrapment and proctolgia fugax. I won't go into detail. Those are the disease of neurological. They are pain due to the neurological element. So you have to take consideration. I won't go into detail of this pudendal entrapment. It occurs because of the injury of the pudendal nerve. It is very well found in the cyclist or due to trauma. whenever do a rectal examination and touch the ischial spine, the patient will shout out of the pain. So this is a very diagnostic criteria of the suspecting of the pudendal entrapment. Now this is also very important, injured anus. This type of anus, the lancet wounds or the lateral fissures with the hypotonic sphincters found in the sodomy patients. Whenever an anal intercourse is made, this type of fissures are made. You have to do just the counseling of the patient and you have to do the wound management. This type of injured anus, mimicking as a fissure in ano, does not require the treatment of fissure in ano. Rather than counseling and wound management of the patient should suffice the treatment. Now see, coming to the main point, management in the acute phase. Acharya Charak has said no. In Vyanavritoppan, the treatment is only in 2 words, Snigdam Anulomayet. So in any type of fissure, we give what we do. In the acute stage, we give the laxatives and we give the Snigdam Ropan Dravyas. So according to the modern, the treatment is always palliative. Toilet training, I'll come to that thing afterwards. Food alteration, you have to say about the pathya and you have to break the vicious cycle. Now see, what is this toilet training? If it opens, I'll show you. Okay. See what has been done these days. That I have seen many patients here. It is the mimicking of a newspaper. Patient go in the toilet with their smartphones. They see all the videos. They like the Facebook post, and they strain at the stools. They sit for hours and hours, and after long straining, a dried fecal bowels is evacuated. This is really bad, and it is seen in most of the youngsters. Patient ko ye batao. Unless and until you don't soil the clothes, you don't strain your clothes, आपके कपड़े ना बिगड़ जाए, ऐसी अर्ज ना आए, तब तक don't go to the toilet. और कई पेशेंट पूछते सर संतोष नहीं हुआ, उनको बताओ टट्टी जाने में संतोष मत लो. If you have a feeling of partially evacuating of the fecal matter, don't worry. It is a waste product of the body and body will throw it out. In 3 to 5 minutes, ask the patient to come out of the toilet and never do straining at their stools. And I have seen many patients sitting in the toilet with their smartphones for 20 to 25 minutes or even more. This was a clinical study. What is used in the modern medicine, lidocaine, hydrocortisone, but laxative with the hot sits bath is more effective than any tropical study. So garm pani mein sek dena and proper laxative. I'll come to a laxative point also. Here, any laxative that is used in our Ayurvedic, dispensaries or hospitals, like Haritaki or Swadhisht Virecharan Churna or Arendapras Haritaki, Shivakshar Pachan Churna, any laxative that is going to bring a liquid stool, a big no. कोई भी ऐसी औषधि, कोई भी ऐसा चूर्ण, कोई भी ऐसी दवाई जो टट्टी को पतली बनाती हो और which is giving liquid stool, it is going to ultimately increase the intensity of the disease. वो कभी अच्छा नहीं होने वाला है. पेशेंट को समझाओ कि टट्टी is effective, but Isabgol is more effective than any other bulk forming laxative or any laxative in the management of fissure in ano. Now, recently it has been introduced first line of treatment, that is pharmacological sphincterotomy. I have used only second and third, diltiazem and nifedipine. Nifedipine along with lignocaine, I have found excellent results. But for that, patient should apply this nifedipine and lignocaine for at least 6 weeks, 42 days. 42 days that proper application of this nifedipine really cause pharmacological sphincterotomy. Spasm of the internal anal sphincter is reduced, and it helps a lot to break the vicious cycle of the pain and the constipation. You have to do the diet modification. You have to give proper laxative if it all required. And these 2 drugs are fantastic in the first line of treatment of acute fissure. Second line of treatment is Botox therapy, that a botulinum toxin is introduced in the intersphincteric plane. It reduces the spasm of the internal sphincter, and by its virtue, the fissure bed is healed. I have never used by myself. Now see, the management of the chronic fissure. For that, you have to understand what is the absolute indication of fissure in ano. The photo that I have shared, that duration should be at least more than 2 months. It doesn't respond to the medical management. There is fibrosis of the internal sphincter, development of the large sentinel bile, and hypertrophied anal papillae. तो एक बात समझ लो, फिशर इन एनो में फिशरेक्टोमी करना and don't relieve the spasm, you are never going to get any result. Good result की भी बात नहीं करता हूँ, any result. Fissure bed को निकाल देना is not the surgical treatment of fissure in ano. So fissurectomy alone is never going to give you any result. So now I will explain you what are the procedures that relieve the anal spasm. See, now this anal sphincter stretch that is very well known as Lord's anal dilatation. Here 1 finger to 8 finger dilatation is done. It is practiced since I think 40 to 50 years, and still I have seen many surgeons who prefer Lord's anal dilatation to relieve the spasm. After doing that, they go for the fissurectomy, and they are getting good results. But we have to advance ourselves, and I'll try to say, or I'll try to explain why you should not do now Lord's anal dilatation. See, what are the advantages? Not much of skill is required. I have stopped doing Lord's anal dilatation from last 8 years. There is no anal wound in that anal dilatation. There is lesser post-op complication and early mobilization. But what are the disadvantages? Recurrence rate. Yes, the literature rate says that anal dilatation does not give good results in the resting anal pressure. There are chances of the incontinence. Why? Because see, अब एक बात समझो. To relieve the spasm of the internal sphincter, why do we damage the external sphincter? External sphincter is voluntary in nature. That is the thing that controls the incontinence. And in the process of Lord's anal dilatation, you remove the spasm of the internal sphincter, but unnecessary damage is done to the external sphincter. That is not required. And more or less, it is controlled in blind procedure. Earlier, it was used, but now it is obsolete. But still, some people do it. They are happy with it. But as far as my view is concerned, in the management of fissure in ano, this should not be applied. See, this is sphincterolysis. This is again a novel concept. What are the advantages? I'll show a video. I'm going to share a video. That is a controlled dilation. Minimal injury to the external sphincters. मैं आपको वीडियो दिखाऊंगा, बताऊंगा external sphincters में कैसे minimum injury होती है. Minimum injury to the mucosa, and practically there is no wound. Most disadvantages, there are insufficient data, and which I can't say because of the data about the recurrence rate. Okay, now so here is the video. Now see, any sphincter, if you want to do this sphincterolysis, first you have to fix the sphincters. Okay, the instrument that is used is the bivalve anal speculum. Now you can see there was a spasm. I have introduced the bivalve anal speculum. Okay, I'll fix the sphincters, and just with this thumb, at a particular point, say for here 4 o'clock or 3 o'clock position, I'm going to break the fibers of the fibrosis that is present in the internal sphincter. You can see here a damage somewhat is done in the external sphincter, but that is minimum. Sphincters are fixed, so this will give me a proper place where I can break the fibrosis. See, only with this thumb applying pressure on the specific point, a fibrosis is broken. And see, here you can see the beauty. There is, the spasm is relieved, and patient is free from the spasm. Ab kuch na karo, you relieve the spasm. If there are the edges are not edematous and the fissure is not fibrous, leave it. The fissure bed is going to heal. ये fissure bed heal क्यों नहीं होता है? Because of the pain and the spasm. I'll repeat this video once again. आप देखो ये spasm was present. This is a bivalvular speculum. मैं internal sphincters को fix करता हूँ. I'll identify any a particular point. I'll use the energy of my thumb. I'm going to break the spasm. I'm going to break the fibrosis. External sphincter को injury minimum होगी. There is no wound. कोई उतनी skill भी आपको use करनी नहीं है. But you have to make sure it is fixed and proper sphincterolysis. आपको feel होगा fibers break हो रहे हैं. This is a novel technique. It is much better than Lord Tunnel dilatation. ज्यादा skill की जरूरत नहीं होती. आप देखो spasm really हो गए अपने आप speculum बाहर आता है. ठीक है. See, posterior midline sphincterotomy. In my earlier days, you can see this thing, 2012. Okay, I was doing posterior midline sphincterotomy. एक concept है, बहुत लोग अभी भी बोलते हैं कि whenever you do a fissurectomy, wound is being created at posterior midline. तो दूसरा wound lateral side में क्यों बनाना है? Just with one wound, identify the internal sphincter and do the sphincterotomy. There is no need of doing the second wound. And in the initial 2 to 3 years of my practice, I was doing posterior midline sphincterotomy, and it was giving me satisfactory results. जब तक आप नहीं देखोगे, जब तक till you don't keep your mind open to the recent trends and works of your seniors or the persons who are more and far advanced than you, you keep on doing the same old thing that you learned earlier. So get yourself updated. I read in the books that posterior midline sphincterotomy is okay, but still lateral internal sphincterotomy is giving more good results, and thousands of patients were documented, and it showed that it is getting far better results, and the recurrence are much less, with less pain and less complication. So, see, advantages मैंने जैसे बताया, sphincterotomy की शुरुआत यहीं से हुई थी. Pioneer of the sphincterotomy, single wound, large open wound, but it is getting more time to heal, and it is more painful also because the wound size is more. There are minor imperfections of the anal incontinence, post-op pain, or literature बताता है keyhole deformity, but I haven't, for my personal experience, I haven't seen any keyhole deformity. Okay, see, this is the thing that the world is doing, that I'm doing, and till date I'm doing this thing from last 7 to 8 years, and I'm more than satisfied. This is open lateral internal sphincterotomy. See what the literature says. You have to give an incision here, 0.5 centimeter in the anal canal, covering the anadome and the anal mucosa, and 0.5 centimeter outside the anal canal. This type of oblique incision has to be given. Internal sphincter has to be identified and should be taken out, and it should be excised with the cautery or the scissor. This is a schematic diagram, and these are the real diagrams. इसकी 2-3-4 technique है. I'll share you in the next videos. See, this instrument identified. This is again a bivalve speculum. ये जो internal sphincter, it is like a tongue. Okay. Without using this bivalve speculum, you won't be able to fix the anal internal.
नहीं रही है फिर हैं बहुत कुछ नहीं चल रही है दुकान ये सरियाना कुछ नहीं हो रहा है पैसा नहीं है तो हो जाएगा दवाई के लिए पैसा तो इंतजार करना पड़ेगा उनसे पूछ ले ऐसे ऐसे वाला फाइल आ रहा हूँ एक बार तो पहले लाया था बोल रहा था रामदेव बाबा का एक बार चेक करने के लिए बोल ना
चीनी आ गया रे पैसा दे दो तो जाओ मैं बैठ दुकान कितना लोन तो घर के बैठ कर ही मिल जाएगा और क्या ऑप्शन है बताओ
ऐसे ही मिलेगा एक बार उनको देखिए मिले क्या करें
हर टाइम मिल जाएगा तो हमें खाली इतना मोबाइल चलाते हो
मेरे से नहीं होता है साथ में
हम बंगाली हो
हम लोग
sphincters, and it is going to slip away. आप उसको आइडेंटिफाई नहीं कर पाओगे, फिक्स नहीं कर पाओगे, and you won't be able to perform the sphincterotomy. This is a video how you should use the bivalent speculum and how you should fix it. Okay. See, when you insert this speculum, and you have to fix this way. You have to fix the way in such a way that the internal sphincter remains static at a point and it doesn't get slipped away. Okay, this is again video. Bivalent speculum. Okay. See now how to perform it. See, an incision with the knife is given here in the intersphincteric plane. A very small incision, not even half centimeter. Okay. Then you have to identify the intersphincteric plane and you have to do the blunt dissection. By doing that, you have to reach up to the level of the dentate line and you have to take out the internal sphincter from the anal canal. We'll see the video. Finding in the in the intersphincteric plane. See, very important. I'm removing this bivalent speculum. This mosquito forceps was hooked at a point. The bivalent speculum is removed, so the tension is released. So you don't injure the anal mucosa. This is a probable complication of the sphincterotomy. See, this is a pure internal sphincter, white fibers. Okay, I am dissecting it with the electrocautery. Whenever I hook that thing, there was a pressure. जब hook कर दिया, I remove the speculum and then I brought it out. After doing that, pinch this wound at least for 1 minute. Okay. Now, just a minute. I'll pause it. Now see, I'm going to show a video of surgical intervention or surgical fissurectomy along with drag excision and the removal of the hypertrophied anal papillae. That is known as a treat of fissure in anal. See, this procedure can be done in many ways. This video I think was taken before 3 years or 4 years. अभी दूसरा video मेरे पास था नहीं. So I'm showing this video. First video I'll show it with the scissor. Second video I'll show it with the electrocautery. Basic principles of the surgery never changes. Okay, see we go to the video. Okay, you have to give a V-shape incision. And we'll try to make the minimum one. Incision was given. You see this? See now this is a blunt dissection. You have to see this, the sentinel tag that you want to excise, you have to remove very nicely from the anal sphincters. And you have to see that you make minimal injury to the mucosa and the anodome. Unnecessary ligation or excision of the mucosa of the anodome is of no use. And it will cause more postoperative pain. See, I'm very finely, I'm doing blunt dissection with the scissors and I'm separating the sphincter fibers from the pathology. And I'll excise up to the hypertrophied anal papillae. See, this sentinel tag I'm separating with the sphincter fibers. And I'll take utmost care. These are the sphincter complex. And you can see the intersphincteric groove. Okay. See, separation and minor dissection is the key over here. In the both sides, I'll take utmost care that I make no unnecessary damage to the mucosa. Now see, now I have catches it. मैं यहाँ पे pause करूँगा और बताऊँगा. See, this entire pathology can be excised. If you are having a very good cautery, you are having a bipolar cautery, you are having a vessel sealer, you are having a laser. Everything can be excised. But see, I work in an institute. There will be surgeons, there will be practitioners, there will be interns who will be practicing in very near future. So earlier, until and unless they don't gain the confidence, I try to I'll show them ligate this entire pathology. After ligation, excise everything. Okay. Many times I excise everything. Sometimes for demonstration purpose, I ligate and do excise everything. See, one more thing. See, now what I have started doing nowadays, that earlier I excised up to here. Up till the pathology, everything I did blend dissection. And I have caught up this entire pathology. Okay. But now, the incision will not cross from here. यहाँ की और यहाँ की म्यूकोजा वैसे ही रहेगी, तो क्या होगा, हेल्दी म्यूकोजा ऐसे जुड़ जाएगी और यहाँ पे जो वुंड बन रहा है वो भी कम बनेगा. उसका भी मैं वीडियो आपको दिखाऊंगा. Now look at this video. Look at the Fisher match. This is the papilla. So now I translate this. Okay. There is no rocket science. I am ligating with Lindenbarber thread. It is 20 number. If you want to translate it with catgut, if you want to translate it with Vicryl, it's up to your choice. With any suture material, because it is going to fluff out within 4 to 5 days. आप absorbable करो, non-absorbable करो. This is really very cost effective और इससे ligation बहुत ही बढ़िया होता है. So I am doing a transligation with the Lindenbarber thread. This is for the upper ligation and 2 to 3 knots. I am asking the patient to release. Okay. See, the entire pathology is ligated. Speculum रखा इसलिए आपको wound size ज्यादा लग रही, इतनी होती नहीं. Now see, the entire pathology is being excised. यहाँ pause किया है मैंने. ये देखो, this is the Fisher bed, this was the papilla, and this was the tag that has been removed. Okay. See. Okay. Working in an institute always promotes me. I always give for biopsy. Okay. Here you can see the wound of the sphincterotomy. Hardly any wound. You can leave this wound open. Okay. Negligible wound. If you want to close this, you can close it. Okay. It is another video of the open lateral sphincterotomy. यहाँ पे मैं speculum बाहर नहीं निकालूंगा. There will be persistent pressure in the anal canal. If this is not done properly, there are all chances you injure the anal mucosa and you create a secondary fistula. Okay. क्या ध्यान रखना है यहाँ पे? Incision रख दिया है. Mosquito से ये मैं आराम से interstitial पेन explore कर रहा हूँ. और underlying mucosa in the skin बाद में मैं mobilize कर दूंगा. This is I'm entering in the intersphincteric plane. Okay. Theoretically and practically, you have to excise the internal sphincter up to the level of the dentate line. Okay. That is sufficient. और उतना तो करना ही है. I am lifting the skin along with the mucosa. I am mobilizing it. ये करने से internal sphincter आराम से बाहर आ जाएगा. Okay, these all procedures are done at my institute. At present, I am working in government Manibin Ayurveda Hospital. Okay, it is all under anesthesia. मैं local में भी करता हूँ. Spinal में 80% of the procedures I do under spinal anesthesia, but local procedures I don't do without the presence of an anesthetist. See, the sphincter is hooked up. Identify कर रहा हूँ. I take proper care. I don't injure the anal mucosa. क्योंकि उससे chances of यहाँ पे focus नहीं आ रहा है, इसलिए आपको internal sphincter नहीं दिख रहा है. Light focus वहाँ जा रहा है. या blade से भी कर सकते हो. It is never going to bleed. देखो, अब सबसे बढ़िया चीज, आपको कभी लग रहा है कि enough fibers of the internal sphincter नहीं आ रहा है, तो वैसे ही रख के उसी surgical space में you can enter again. You can enter again. See, I'm entering here again. Again, bring out the internal sphincter. outside and do sacrifice it. The beauty of the Fisher Nano surgery lies in how well, with minimum invasive parameters, you relieve the spasm of the internal sphincter. And this is the best procedure, sphincterotomy, the lateral one. Okay. Resting anal pressure के लिए anal manometry होती है. If you proper data is done at any educational institute after procuring the anal manometry, I'm very sure this will give the best result. Okay. See, this is a video. I'll show you with Agdi Karma. Okay. I'll do with the cautery. See, this is again a sphincterotomy. I'm not using here any cautery. Basic concept of the surgery. आप शुरू में कुछ भी सीखो, आपको चाकू चलाना आना चाहिए. See, here I have made an incision with the blade. Most important surgical plane is the intersphincteric plane in the Fisher Nano. I'm doing blend dissection. I have entered in the intersphincteric plane. I book the internal sphincter up to the level of the dented hand. Now, see, for the demonstrative purpose, I will excise this internal sphincter with the help of the blade. It is never going to lead. Okay, yes, this is Jai Krishna. It's over. Okay. You can do with the electrocautery. You can do with the scissors. You do with whatever you are feeling comfortable. Electrocautery से होने में wound healing में 2 से 3 दिन ज़्यादा लगेगा. 1 या 2 टेबलेट डायनापार एनाल्जेसिस को ज़्यादा लगने लगेगी. लेकिन with this much time, I'm more comfortable with the electrocautery. We can do it with the scissor, but I'm more comfortable with the cautery. Okay. I'm separating the pathology with the sphincter bundles. See, this thing has been caught up. Just a minute. थोड़ा पीछे ले जाऊंगा इसको. आपको एक चीज दिखानी है. Yes. See, here you can see the hypertrophied anal papillae. Here is the Fisher bed and this tag. This everything will be transligated and it will be excised. Never close. See the pathology. See, I send it for the biopsy. I send it. Here you can see the Fisher bed. This is the sentinel tag. आप कितना भी इसको दवाई खिला दो, जात्यादि तेल के कुएं में नहला दो, कितनी भी बस्ती दे दो, ये ठीक नहीं होने वाला है. कर्कश स्थिर पृथु कठिना अग्निना. This head has to be dealt with the surgical or the parasurgical procedure. This treat of the Fisher Nano, if we are doing or managing with the conservative aspect, we are doing a medical crime. इसको बता दो ये नहीं ठीक होने वाला है. Thank you, sir. Okay. See, this is the specimen. I always send for biopsy. This is again a video. This is a video of fissurectomy with CO2 laser. बहुत सारे पेशेंट प्राइवेट में आएंगे, सर लेजर है तो मैं करवाऊंगा. See, डायरेक्ट कांटेक्ट नहीं होता है. This is a tag excision along with fissurectomy with CO2 laser. A beam of CO2 is applied very gently around the Fisher bed. ये लेजर यूज करने में it is not a rocket science. You should know the practical or the primary aspect of the surgical management of any procedure. Then these gadgets you can use very nicely. इसका यही एक फायदा है. It costs minimum chairing. wound healing थोड़ा फास्ट होता है. पोस्ट ऑपरेटिव पेन थोड़ा कम होता है. लेकिन the cost of gadgets, I won't suggest anyone, any practitioner, ये CO2 लेजर ले. इनफैक्ट अभी जो लेजर चल रहा है फिशर नैनो या पाइल्स में, लेजर की कोई अहमियत नहीं है. इट इज जस्ट एन गिमिक. मैं बहुत ही बोल्डली बोलूंगा, लेजर पेशेंट को बोलते हैं लेजर है तो आप करवाऊंगा वरना मैं नहीं करवाऊंगा. तो आई हैव नेवर प्रैक्टिस्ड इन प्राइवेट सेटअप, बट आई नो फॉर वेरी श्योर that it is just for the satisfaction. It is just a gadget gimmick. In proctological aspect, especially in hemorrhoids and fissure, laser have no additional role. See, the entire pathology is being excised. ये पेशेंट को मैं सेडिशन दिया है और लोकल में कर रहा हूँ, इसलिए वो बोल रहा है. आप देखो यहाँ पे थोड़ा फॉरवर्ड करूंगा. लिमिटेशंस ऑफ टाइम. Nicely excised with CO2 laser. 100%. This is going to give a little bit of less post-operative pain, and it will heal up faster, 2 to 3 days than the conventional surgery. That's it. ऐसे सिंपल केसेस में चलता है. जो अर्लियर मैंने वीडियोस बनाए हैं उसमें ये CO2 लेजर डेफिनेटली उतना अच्छा काम नहीं करेगा. ओके, so this is over. Fissurectomy with TEG excision with CO2 laser. Closed internal sphincterotomy. See, जैसे ओपन किया, we made a wound, we took out the sphincters from the anal canal, and under direct vision we did excise it, and we are very much confident. Closed lateral internal sphincterotomy वही होता है, लेकिन the anal sphincter is not taken outside the anal canal. So this is my procedure. External sphincter, internal sphincter, intrasphincteric groove. You have to enter from here. यहाँ पे देखो मैंने I haven't applied the bivalve anal speculum. ये उतना ठीक से नहीं होगा. अगर speculum इस पे डाला होता तो ये अच्छी तरह होगा. See, this video specially I am seeing you that without the bivalve anal speculum you cannot perform sphincterotomy in the desired way. See, procedure वही रहेगी. Knife I have inserted in the intersphincteric plane. This is a step knife, 11 number. I am rotating in the direction of the anal canal. I am cutting the sphincters appropriately. Then again I am reversing it, and I will take out. Yes, that's it. See, this requires too much of expertise. The chances of complications are high. If you are confident, you can do it. I do open lateral internal sphincterotomy. So this is a chart comparing open and closed lateral internal sphincterotomy. So these are any surgical procedure has its complication. These are the probable complication. But if you do it nicely, ये कुछ नहीं होना है. V-shape incision ऐसे मत दो, ऐसे दो. Okay, this is the right, this is wrong. In the acute fissure does not heal with conservative, then what? सबसे पहले सोचो ये फिशर ही है या और कुछ है, सेकेंडरी तो नहीं है ना. So this is very important slide. कंजर्वेटिव से acute fissure heal होना ही है. अगर नहीं होता है then think about your diagnosis. वहां पे कुछ गलती हो सकती है. If you are done lateral internal sphincterotomy और recurrence हो रहा है, then what you have to do? First talk to yourself. Was your diagnosis right? Secondary fissure in ano tha, any underlying cause था? अगर नहीं था, was the operation done effectively? Spasm ठीक से relieve किया तूने, dilatation किया, sphincterolysis किया, sphincterotomy किया. अगर किया है, then how about the resting anal pressure? वो कम हुआ? अगर हुआ तो वो कम ही रहना चाहिए. Resting anal pressure should be made under its limits. अगर वो फिर से बढ़ जाएगा तो फिर से फिशर होगा. अगर ये सब ठीक है, then what you should do? तो पहले tincture of time, give it a time, counsel the patient that some patient take time to heal the fissure. कहीं को 7 दिन में ठीक होता है, some take 7 weeks. अगर आपको लग रहा है then again there is spasm, then you again have to do sphincterotomy, but compulsorily open type. आप देखोगे आप क्या काट रहे होगे, और जहां से पहले अगर आपने 4 o'clock किया है तो इस बार 8 o'clock करो. ठीक है, पोस्टीरियर किया है तो एंटीरियर करो. अगर ये सब करने से भी fissure bed is not healing and your diagnosis is right, then the last option is anal advancement flap. I'm having the video, but due to limitation of time, I won't able to show you. Now, so looking for the best treatment. What is the best treatment for fissure in ano? Best treatment is वही surgical procedure या वही palliative treatment which resolves the pain, We have to make patient pain free. हर सुबह टट्टी में जाए, वो चिल्लाए, वो डर जाए. That is not done. You have to resolve the pain. You have to heal the fissure, and you have to make patient understand the pathya do's and don't. That the fissure bed remains in the healed phase. You have to maintain the continence. Sphincterotomy karo. So there can be partial incontinence of the flatus or the liquid stool, and you have to keep the fissure bed healed. And this is the best treatment. So conclusion, what is gold standard? At till date, gold standard for relieving the anal spasm is lateral sphincterotomy, open or close, it's your choice. And आज ये मैंने बता दिया, this is ये कोई ब्रह्म वाक्य नहीं है. Keep your minds open, accept the new trends, and get yourself updated from time to time. यदि हस्ति अन्यत्र यन्ने हस्ति न कत्वचित, ये बहुत ही जरूरी है. लेकिन चरक ने ये भी बोला है कि हमारे शास्त्र के अध्ययन के साथ दूसरे शास्त्र का भी अध्ययन करो. So anything that is new, get yourself updated and accept the new trends. आज मैंने ये सीखा है, पूरी जिंदगी हम यही करेंगे. Not done, sir. So this is the public view. This is the proctologist view. I always try to get myself updated by reading, experimenting, learning, and sharing my views with you. So thank you very much, and I hope this lecture should help you in resolving the pain of fissure of your patient. Thank you very much. Namaste. And again, I thank Shreyas E-Learning Academy to give me this chance to share my views with you all. Thank you very much.
For you this valuable session. Hello.
Hello, sir.
Hello.
Yes, sir. Yes, sir. Am I audible, sir?
Yes, sir. Sir, on behalf of Shreyas E-Learning Academy and all delegates, we express our thanks for this year today. If someone has any query, then we can just. Sir, there is a question in chat box. Can you access them?
Sir, I'm not able to get what you are saying. Please say the question, sir. I'm not. I did not get what you said, sir.
Sir, there is a question in chat box. Can you please?
Okay. Okay. Just a minute, sir. Okay. Okay.
So, yeah.
What while doing lateral entrance sphincterotomy, there is a damage to the mucosa, then how to treat it further? Sir, then there is no immediate treatment. If you damage the mucosa, just do the wound management. Don't close that, sphincterotomy wound. Let it remain open. Wait for the secondary healing by secondary intention, and keep a close watch that it does not develop into abscess or a fistula. Okay, and in these cases, you can prolong the course of your antibiotics for about 2 weeks. You can definitely give the antibiotics, and you can do the proper wound management. And don't close that wound. If you have injured the anal mucosa, don't close that wound. Let that wound remain open and healing by secondary intention. Any more questions, sir?
No, sir.